Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Arun Kumar Chopra. Sir is MBBS, MD, DM Cardiology, Director Cardiology at Fortis, Amritsar. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is role of combination therapy in lipid management. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Sriyam. And today, the topic that I'm going to share is the role of combination therapy in lipid lowering and how we need to go an extra mile as far as this is concerned. So, I shall divide my presentation into the rationale behind the use of combination therapy and then discuss a stepwise approach as well as a rapid onset approach to start combination therapy and share briefly the current guidelines in this regard. So please go to the next slide. So dyslipidemia, as you know, is an extremely important risk factor for atherosclerotic cardiovascular disease. And as you know, nearly 18 million deaths worldwide each year are due to CVD, of which 85% are due to atherosclerotic related events. And dyslipidemia is one of the most important, perhaps the most important risk factor for ASCVD. Next. So in India, we know that coronary artery disease risk is much higher than in the Western world and than in rest of Asia. So Asian Indians are at an extremely high risk of coronary artery disease. As you can see, they are at a 3 times higher risk than Americans, 6 times higher risk than Chinese, and 20 times higher risk than Japanese for getting ASCVD as well as mortality related to ASCVD. So it is also important to note that India has a much younger population of CVD. In India, the average age of development of CVD is roughly 8 to 10 years younger than in the Western world, with 25% of MIs in India occurring under the age of 40, and nearly 50% of all deaths related to coronary artery disease occur in individuals below the age of 50 years. Hence, ASCVD and its risk factors, especially dyslipidemia, are an extremely important public health problem, and we need to deal with it very expeditiously. Thank you. Next, please. So we know this slide very well, and this is broadly speaking the linear association between risk of developing coronary artery disease and LDL level. And as you can see, going from a very low level of maybe around 40 to 50 milligram per deciliter of LDL, as we go higher and higher in LDL to above 100, above 200, and so on, the risk of coronary artery disease also keeps on mounting. Next, please. So, similarly, we know that conditions which bring down lipid levels or which increase lipid levels for some reason, this is on the left, the panel shows the Mendelian disorders which are associated with congenitally high or congenitally low LDL levels. We find that the risk of coronary artery disease rises or falls as per the LDL cholesterol levels. And similarly, if we look at the panel on the right, we find that in primary prevention as well as in secondary prevention, as we bring down LDL levels by the use of effective drugs, especially statins, we find that there is a reduction in the risk of coronary artery disease, which parallels the reduction in LDL cholesterol, which accounts for this nearly linear relationship between coronary artery disease and LDL cholesterol levels. Next, please. So this is a very important chart, and let us spend a minute on this. If you see, this shows cut points of LDL 50, 100, 150, 200, and there is this small green line, thin green line just above 150. So if you can see that, that is supposed to be the supposed threshold for coronary artery disease. And healthy individuals who do not have too many risk factors typically achieve this level of risk after the age of 55. That's why it is accepted that after the age of 65, coronary artery disease may be present. On the other hand, if the patient has gross abnormalities of lipids, for instance, if you see the first line on the left, which is the dotted line in blue, this signifies homozygous familial hypercholesterolemia, where LDL levels are extremely high. LDL is typically more than 3 400 in these patients. We find that the risk of coronary artery disease can occur much earlier. Look here in the panel on the right, where we find that as early as the age of 12.5, when the patient is actually a young child, they may get coronary artery disease or stroke or other atherosclerotic events. Heterozygous familial hypercholesterolemia, these are patients whose LDL levels are typically over 190, often in the range of 200 to 300. We find that this threshold is reached earlier than healthy population, that means around 35 years or so of age, but later than homozygous familial hypercholesterolemia. So here we need to understand that risk factors can be positive or negative modifiers here. And in this regard, for instance, female gender, or regular exercise, or maintaining a healthy lifestyle is a uh, positive modifier, in the sense that it delays the onset of coronary artery disease beyond 55 years, or the same levels which I mentioned in these hyperlipidemia syndromes. On the other hand, there are risk factors which worsen the risk of coronary artery disease, and these are our classical risk factors like smoking, hypertension, diabetes, dyslipidemia. In other dyslipidemias, that means high triglycerides or low HDL or high lipoprotein little a, all these increase the risk of coronary artery disease and shift the curve to the left. That means that one can get CVD events earlier than the predicted time. Next, please. Next slide, please. Okay, so now we know there is good data from the cholesterol treatment trialist collaboration, which shows that if we bring down the LDL cholesterol level by about 1 millimole, that means by nearly 40 milligram per deciliter, there is a 21% reduction in CVD events. Therefore, since we have effective, potent therapies which reduce LDL even further by about 2 to 3 millimoles of LDL cholesterol lowering, that means to the range of 80 to 100 milligram per deciliter lowering than baseline, we can achieve ASCVD reduction by at least 50% using high dose statins, or using moderate dose statins with other drugs in case high dose statins are not well tolerated. Next, please. So we know that high dose statin therapy is extremely effective. It reduces not just CVD events but also mortality, and especially in high risk individuals, secondary prevention. Primary prevention is more controversial. But even with effective statin therapy in high risk individuals, you can see that residual risk remains. So the placebo columns are in red and the statin columns are in green. As you can see, there is significant reduction in the risk of getting an event with statin. Nevertheless, statin events are not zero. As you can see in all the trials, statins reduce the risk of cardiovascular events by 25 to 30%, in some even somewhat more, but not to zero, obviously. And therefore, nearly 70 or 75% of the atherosclerotic burden is not corrected by the use of statins alone. So we need to do something more. Next, please. So we need to look at what are other strategies of lipid lowering apart from statins, which may help increase the benefit of lowering lipids further than that achieved by statins alone. So apart from statins, we have selective cholesterol absorption inhibitors like ezetimibe. We have ACL inhibitor, ATP citrate lyase inhibitor, that is bempedoic acid, and we have PCSK9 inhibitors in the form of monoclonal antibodies or small interfering RNA, which is recently available now in India also by the name of inclisiran. Next, please. So, if we add any of these drugs to existing statin therapy, we find that the risk of getting MACE, that means usually a composite of CV death, non fatal MI, unstable angina, coronary revascularization, or non fatal stroke, is significantly lowered by the combination of non statin therapy with statins. So, in the IMPROVE trial, we saw that the addition of ezetimibe to ongoing statin reduced LDL by another 20% and achieved a 2% reduction, absolute reduction in cardiovascular events. Next, please. Similarly, in the REDUCE-IT trial, the addition of icosapent which is omega 3 fatty acids in a very heavy dose of 2 gram twice daily, we find a 20% reduction in the risk of CV death, MI stroke in the very well known REDUCE-IT trial. Next, please. As we go on, we look at the data of PCSK9 inhibitors, and evolocumab in the large 4-year trial with 30,000 patients achieved a nearly 60% reduction in LDL levels to a level of around 30 to 35 milligram per deciliter. Next, please. In combination with high dose statin therapy, and we find that there is a significant 15% reduction in the risk of the composite endpoint and an even greater reduction of almost 20% of cardiovascular death, MI stroke. However, please note that this risk reduction is mainly in MI and stroke. Cardiovascular death was not significantly reduced in this trial by the use of PCSK9 inhibitors. However, because of the overwhelming reduction in MI and stroke, this trial was terminated early, and this drug was approved for use in prevention of high risk coronary artery disease. Next, please. So the Odyssey trial, which had alirocumab, again almost 30,000 patients, there is a 15% reduction in the cumulative endpoint, and here there was some mortality benefit also, which resulted in the approval of this drug also for the use of in high risk patients for secondary prevention. Next, please. So why do they act? And for this, we have this study, the Glegov trial using evolocumab. We find that there is greater reduction in percent atheroma volume. That means there is actual regression in atherosclerosis in the coronary arteries, which is much more than that seen with statin monotherapy alone, which probably accounts for the reduction in risk of ASCVD events. Next, please. So another drug which has come up, inclisiran, as I was telling you, this is small interfering RNA, which reduces the LDL levels by nearly 50%. And the advantage of this is that after an initial dose, you need to give a dose only once in 6 months. The major problem with PCSK9 inhibitors was fortnightly injectable lipid lowering therapy, and people had difficulty in doing that. It is expensive also. On the other hand, inclisiran, though somewhat more expensive as a single injection, has the advantage that it is to be used once in 6 months, and with its once in 6 months use, it brings about a 50% reduction in LDL levels from the baseline. Next, please. So this is currently undergoing trials, and we expect results in the next couple of years. This has been prematurely introduced because of safety data, though outcome data are yet to come in. The next is bempedoic acid, which is an ATP citrate lyase inhibitor, and it acts further on stream of HMG-CoA reductase, the enzyme on which statins act. And what we find is that they bring about a significant 15 to 20% reduction of LDL levels in statin intolerant individuals. So, this is a drug which was brought about for statin intolerant patients, and its combination with the ezetimibe, and this combination is now available as a fixed dose combination, brings about a significant 38% reduction in LDL levels on top of maximally tolerated doses of statins. Next. So, if we look at the combined data of non-statin trials, a meta-analysis of Improve It, Reveal, and Fourier trials, it examined 50,000 patients. What we find is that the median LDL in the control arm ranged around 70. There were in excess of 9,500 major vascular events. Non-statin therapy lowered LDL cholesterol by an additional 11 to 45 milligram per deciliter and reduced major vascular events by 21%, which is a statistical significant reduction. Next, please. So, based on the results of these lipid lowering trials, as you can see, starting in the 90s, going on to very recently with the PCSK9 inhibitors, we find that there has been gradual evolution in the lipid cutoffs that are recommended for treatment as well as goal in the prevention of coronary artery disease. And I will briefly share them in the next few slides. So, if we look at this, we classify cardiovascular risk as very high risk, intermediate risk, and low risk. So, very high risk are those individuals with documented ASCVD, especially those who have had an ACS or a previous procedure, diabetes with target organ damage or very long duration, more than 20 years, and or severe CKD or a calculated score risk of more than 10%, 10-year risk of fatal CAD. Next, please. And of course, familial hypercholesterolemia. So, high risk category is somewhat lower, and then of course we have moderate risk and low risk categories. Low risk categories are individuals who have a calculated score of less than 1% of 10-year risk of fatal CVD. Next, please. So once we have divided people into these four categories, we give them LDL goals. So based on the data, the ESC currently recommends that in low risk individuals, we aim for a goal of LDL less than 116, for moderate risk less than 100, for high risk less than 70, and for very high risk individuals, we aim for a 55 milligram per deciliter LDL goal, and we try to aim for at least a more than 50% reduction of LDL from the baseline. Next, please. And this is the stepwise approach which they suggest. Start initially with high dose statins, check the patient at 6 to 12 weeks. If the goal is achieved, well and good. If not, add ezetimibe. Then continue, check again after 6 to 12 weeks. If the goal is achieved, well and good. If not, add a PCSK9 inhibitor. So this is the sort of stepwise approach that has been advocated in the last 4-5 years. Next, please. So let us examine, on the other hand, what is the current status of lipid lowering therapy globally. Next, please. So if we look at this study, the EuroAspire study, which was presented in 2019, we find that 71% of individuals in Europe across 27 countries did not reach their LDL goal as prescribed by European Society of Cardiology. Next, please. A more well-known study is the Da Vinci study, where 18 countries of Europe were taken, nearly 6,000 patients taking drugs for primary or secondary prevention. Next, please. And they tried to find out how do these patients behave on statin therapy and combination therapy when we use either 2016 goals or 2019 goals. And what we find out is that at that time, this is a study done between 2015 and 19. What we find is that 84% of people were on statin monotherapy, only 10% were on combination therapy, and statin monotherapy achieved 53% goal as per 2016 guidelines, but only 30% of the individuals achieved goal cholesterol levels based on 2019 guidelines. And if we look at combination therapy, the ones in blue, we find that even with the addition of ezetimibe and PCSK9 inhibitors, only 60 to 70% of individuals could actually achieve the 2019 goals. 30% couldn't. Now, in this regard, data from Europe seems to be different from the data in India. And what we find is that with high dose statins, a larger proportion probably achieve goal LDL levels in India. We also seem to have somewhat more statin intolerance than that in the West. Nevertheless, combination therapy is probably required in a significant proportion of our patients too. Next, please. So, in very high risk subgroup, what we find is that an even lower percentage, 45% achieved 2016 goal and 22% achieved the 2019 goal with high dose of statins. Next, please. So, what we basically find is that a large proportion of people in very high risk individuals, nearly 80% of individuals are not reaching their LDL goal by the use of statins alone, at least in Europe. Next, please. SANTORINI study. This came up much later. This came in June last year. So if we think that the data from EuroAspire and Da Vinci study are old, they are 5 years old. So maybe things have changed. What we find is things haven't changed too much. In 9,000 patients here in high risk or very high risk subgroup, 21% were actually on no lipid therapy. Combination therapy had increased to about 24%. Statins alone were there in 50%, but only 20% achieved the LDL goal as per ESC 2019 guidelines. Next, please. Next. So what we find is also another worrisome point that nearly 50% of individuals discontinued their statins within 2 weeks of starting therapy, and this number is much more in individuals prescribed statins for primary prevention than it is in those advised statins for secondary prevention, obviously. Next, please. So, what is the way out? The way out is a committed approach towards lipid lowering in the high and very high risk individuals, early consideration of combination therapy with a consideration as to whether we should follow a slow stepwise approach or whether we should go for early combination therapy. Next, please. So, how much does statin dose doubling help versus adding another drug? So, if we look at the benefit of increasing the dose of statin, we find that doubling the dose of statin reduces LDL cholesterol further by only about 5 to 6%. So 20 milligram of atorvastatin is nearly 90% as effective as 80 milligram of atorvastatin. Thus, there is not too much gain out of doubling the dose of statin. after achieving 20 milligram atorvastatin or 10 milligram of rosuvastatin. On the other hand, the side effects increase significantly when we double the dose of statin. Therefore, it might be more advisable that once you've achieved a dose of 20 to 40 milligram atorvastatin, you should give consideration to adding another drug rather than increasing the dose of statin further. In this regard, the addition of ezetimibe reduces LDL further by 20 to 25%, bempedoic acid by another 40-50%, PCSK9 inhibitors by 50 to 60%, and inclisiran by about 50%. Next, please. So, put together, if we use all these drugs, we can achieve up to an 85% reduction of LDL cholesterol by the use of high dose statin with ezetimibe and PCSK9 inhibitor or inclisiran. Next, please. And even in statin intolerant patients who can just tolerate maybe 10 milligram of atorvastatin, and some of them not at all, the use of bempedoic acid, ezetimibe, and PCSK9 inhibitors can achieve a more than 60% and often more than 70% reduction in LDL cholesterol levels. Next, please. So these are the current ESC guidelines 2023 for lipid lowering therapy in ACS patients. And it is suggested that those who are not on lipid lowering therapy should be initiated on high dose statins and consideration given to the use of combination therapy. In those who are already on statins, one should increase to the maximum tolerated dose of statin plus consider adding another drug. In case there is no other drug earlier other than statin, we should add ezetimibe. In case ezetimibe is also on, we should add PCSK9 inhibitor. So whatever be the drug which is started, a repeat lipid profile should be performed early by 4 to 6 weeks in the OPD. And if at this stage one has achieved LDL cholesterol goal of less than 55 with, let's say, statin alone, well and good. Otherwise, we add ezetimibe. If with this combination the LDL goal is achieved, well and good. If not, we add PCSK9 inhibitor. And if high dose statins are not getting tolerated, we go to a lower dose of statin, let's say 10 milligram of atorvastatin, and add bempedoic acid instead. Next, please. So if we go by the traditional step-by-step approach and check lipids every 3 months or so, it would take at least 1 year to achieve optimal therapy. And we may not have that sort of time because we know that the risk of getting a repeat event is the highest in the first 1 month and especially in the first 1 year after an acute coronary syndrome. Though level of risk remains high for another 4 to 5 years after the event. On the other hand, if we use early combination therapy, that means within 4 to 6 weeks, the patient is on combination therapy if required, then we are likely to reduce the risk of these early recurrent events. Next, please. So this is the sort of guideline that is available at the moment, which I discussed just now. So in individuals who are at extremely high risk, we need to consider not just a statin, but also give consideration to the addition of ezetimibe if the patient appears to be extremely high risk. And if we don't achieve goals within 4 to 6 weeks, we consider adding PCSK9 inhibitors. Next. So this is the guideline from Lipid Association of India, which are in similar lines, but they are somewhat more aggressive. They consider repeating lipid every 2 weeks and then increasing therapy. We don't have good data for this yet, but in the extremely high risk Indian population, where we know that the risk of getting recurrent events is higher than in the West, we do need to be more aggressive. Though I personally favor the repeat lipid at 4 to 6 weeks strategy. Next, please. So as you can see, using combination therapy, we can achieve 85% reduction of LDL cholesterol levels in almost all patients, in all subgroups, including ASCVD, including familial hypercholesterolemia, and including complete statin intolerance. And therefore, we must go towards achievement of these LDL cholesterol goals and not sit down with complacence after having just started one drug, that is statins. Next, please. So, to conclude, friends, LDL lowering is of paramount importance in the management of high and very high risk subjects with ASCVD. Statins alone help achieve the goal in less than 50% of such individuals. Combination therapy can help achieve LDL goal levels earlier and with lesser adverse effects. Upfront combination therapy is now being studied and is coming up in very high risk subjects, that is ASCVD patients with multiple risk factors, those who have had recurrent ACS within 2 years of the index event, FH with associated ASCVD, and due consideration is also being given whether all ACS individuals should be initiated directly on combination therapy right from the beginning. So, with that, I would like to conclude and thank you all for your patient listening.
Thank you so much, sir, for the wonderful presentation. So, sir, we do have some question if you like to take that up from our
Sure.
audience. Yeah. So, sir, the first question is, what are the potential risk or adverse effect associated with combination lipid lowering therapy?
So, like I shared just now, increasing the dose of statin gives a lesser increase in benefit. That means doubling the dose of statin from any dose increases its efficacy by only about 5 to 6% extra reduction in LDL. On the other hand, addition of these drugs brings about an extra reduction of LDL cholesterol by 20 to 50%. Therefore, it is easily imagined that the benefit of combining two drugs is more and the risk of adverse events is lesser, because ezetimibe, as you know, is a very safe drug, has almost no side effects. Its side effect profile is similar to that of placebo, and therefore, instead of increasing the dose of statins to very high levels, where the risk of liver function derangement, muscle aches and pains, rhabdomyolysis is of course less common, risk of diabetes, peripheral neuropathy, cognitive disturbances, all those issues can crop up in the long run. Using a moderate dose of statins, I would suggest maybe 20 to 40 milligram of atorvastatin or equivalent dose of rosuvastatin in combination with ezetimibe actually would cause lesser side effects than high dose statins alone, but bring about greater reduction in LDL and probably greater reduction in CVD events.
Thank you, sir. The next question is, what are the current gap in research regarding combination therapy for lipid management?
So current gaps are that we have data only showing reduction in CVD events with combination therapy. We don't have data showing mortality benefit. If we look at secondary prevention trials of statins like 4S trial, we have good data to show that statins not only reduce CVD events, they also reduce mortality. That means they improve survival. On the other hand, none of the combination therapy trials, neither with ezetimibe, nor with bempedoic acid, nor with PCSK9 inhibitors, has brought about reduction in mortality. All of them have brought about reduction in CVD events. So probably we need longer trials with these combination agents so that we can show mortality benefit. Therefore, the reluctance of some physicians to initiate these therapy goes down. And in case there is an issue with these drugs combinations, we should also find that out so that we then know that we need to do more.
So the next question is, how to control lowering HDL and triglyceride in CKD diabetic patients?
Sorry, how to control?
Lowering HDL and triglycerides in CKD diabetes patients.
I'm not sure that I understand your question properly. There is probably
It's an
some
issue. So
problem
let's
with
just
this
skip it.
question. So, in diabetic and CKD patients, we cannot use very high doses of statins in CKD In in CKD patients, we should use atorvastatin in preference to rosuvastatin because there is data to show that 40 milligram rosuvastatin can reduce the GFR, whereas 10 milligram of rosuvastatin is generally well tolerated. So in CKD patients, atorvastatin is a better drug than rosuvastatin. Secondly, high dose statins are generally not well tolerated and not shown to be useful in most patients with CKD. So, an acceptable dose would be 20 milligram of atorvastatin or equivalent of rosuvastatin, and we should consider combining other agents in view of their greater efficacy and lesser side effects. In diabetes, of course, the usual guidelines which I just mentioned will hold true. The problem, and one more problem with the CKD is that fenofibrate should generally be avoided in advanced CKD.
So there is one last question. So what role do genetic factors play in determining the effectiveness of combination therapy in lipid management?
So we don't know about that as yet. There are lots of genetic factors. Definitely, we see that there are some people who, with just a 10 milligram dose of a torvastatin, come down with their LDL levels from 190 to 70. And there are others who, with the 40 milligram or 80 milligram of atorvastatin, come down only from 190 to 120. So this could be in part due to other factors which are not normally calculated. For instance, lipoprotein little a. If an individual has high lipoprotein little a, then this is not lowered by statins. In fact, LP little a may increase somewhat with statins, and therefore individuals who have high LP little a will need either inclisiran or a PCSK9 inhibitor to lower LDL levels to goal. But this is just one factor, and there are, I'm sure, several other genes. There are at least 100 genes associated with cholesterol levels, and we know very little about them. And it is a number of different genes with small effects which lead to a polygenic sort of inheritance, and we can't really give clear idea about this. So we have to examine a patient individually. So we start the therapy and check the lipids again after 4 to 6 weeks to see if we have achieved goal or not. If we have, well and good, we follow up the individual. If not, we add an additional drug.
Sorry, sir. Thank you for answering all our questions, sir. So, sir, before concluding, any last remark from you, sir?
No, thank you. I think this was an important subject to be discussed. So I have tried to cover most of the salient features which one can in a small period of 30 minutes or so. But if there are any other questions, they can be directed to me and I'll be happy to answer.
Thank you so
Of
much,
my-
sir, for joining us today. Thank you so much, sir.
Okay, thank you.